Hello, I'm Dr. Derek Lee. It's my pleasure to introduce Dr. Carl-Eric Aubin, who is a full professor with the Department of Mechanical Engineering at Polytechnique Montréal, researcher at Saint-Justine University Hospital Center, and associate professor with the Department of Surgery at University of Montreal. He also holds two chairs, the Canada Research Chair in Orthopedic Engineering and the NSERC Medtronic Industrial Research Chair in Spine Biomechanics. Welcome, Dr. Aubin.
It's my pleasure.
Okay. Now, I'm really looking forward to today's interview because you're on the front edge of research. Been looking through many of your publications. But before we get into that, I was wondering if you could talk a little bit about how you became interested in engineering and throughout your career, eventually focusing quite a bit on scoliosis research.
Well, when I was young, I was interested in both medicine and everything technical. And biomedical engineering was probably the right option or the right combination, but at that time it was not existing, it was not well developed. And that's when I started my university in mechanical engineering. And it was there that by a happy coincidence, I met a professor who was working on scoliosis. And he offered me a summer internship on modeling the orthotic treatment of scoliotic spine. And I joined this challenge so much that I'm still there 30 years after, still working on the same topic.
Excellent. Now, it's funny how once your career path, so he was a major influence in terms of
yeah.
Okay. And if we can focus a little bit on adolescent idiopathic scoliosis, it's multifactorial, it's idiopathic for a reason, because there's so many variables that it could be. But there seems to be, just speaking to different surgeons, a little bit of consensus regarding once scoliosis is triggered, what leads to progression is RASO or RASO in terms of relative anterior spinal overgrowth. And I think some surgeons feel, and some researchers feel, that it's the actual anterior of the vertebra that might be increasing. Others feel it's maybe currently mostly the disc that's increasing. Do you have a perspective on that?
Yes, sure. In fact, bone growth is a dynamic biological process that is governed by mechanical forces. So we know from a long time that overcompression of the bone slows the growth rate, whereas bone that is less compressed or distracted will have a faster growth rate. So the RASO concept is based on the fact that the spine is more compressed in the anterior column due to paradoxal lordosis, which explains in certain cases the slowing down of the growth rate of the anterior spine, which leads to a hypokyphosing process. And in certain cases, there are instability, and rotational component shifts this slowing process on the side, and which shift in the coronal plane, which explain the torsional aspects of the spine, the lateral deformity, and a reduction of the kyphosis, which is seen in a great proportion of cases. So it's a dynamic process, which the mechanobiology is certainly an important factor that is at play for the deformation process over time.
Okay, so it's just hard to isolate, I guess, the vertebra from the discs. They're complete motion units, and it's very difficult to say whether one is more so than the other. Is that correct?
Yeah, in fact, the disc is a much more flexible part of the spine, and at first it is the first to deform with the asymmetrical forces because it's the softer part of the spine. So initially, it's more an elastic deformation, but then it becomes permanent. And also the asymmetrical forces, which happen at some time where you have an initial deformity, will at a certain point will modulate the bone deformity, and so this is why the deformity happens in the bone after, and but bone deformity is more permanent. So this is, but in fact, it's a growing, it's a dynamic process, and at the end, the forces are in the system. They are not disappearing; they are all there. But the disc is more is a more softer component which accommodate and at a certain point will deform, but the bone will be the most important aspect that will lead to a permanent deformity over time.
Okay. Well, even though the disc is soft tissue and it's pliable, does there become a certain time period when the disc will stay in that wedge shaped regardless of the bone?
Yeah, this is what it is saying. Okay. The difficulty is when you take an X-ray, you measure a deformity. The bone, for sure, it's a permanent deformity because the bone will not deform more if you move. But if you move, then the disc wedging will change. But we know that the disc will rigidify over time. So it may be more permanent after a while, yeah.
Okay. Now, have you seen, well, it seems with the RASO, and from other surgeons I've spoken to, the thoracic spine seems to have much more of the shearing forces for the disc. Is that correct? And is it the thoracic spine that drives the vast majority of hypokyphosis and scoliosis?
In fact, the shearing in the spine is seen at every level, but in fact, the forces that are coming from the muscles and the one from the gravitational loads balance at a certain point. So we know with the RASO concept that the forces are more important in the anterior spine, which may lead to hypokyphosing or low-dosing effect, which then becomes on the side. So it's difficult to truly answer this. And but for sure, the thoracic spine is less mobile than the lumbar spine. So, and the forces are higher in the lumbar spine. So sometimes it's not an isolated problem. It's a global system.
Okay, because I was always wondering with predominantly lumbar curves in terms of scoliotic curves, do you notice quite a significant amount of RASO there as well in terms of an increase in lower doses that drives the lumbar scoliosis?
I don't know exactly. I think most of the scoliotic deformities, at least in adolescents, are thoracic. So I think this is where the RASO concept is more seen, as this is lower dosing effect of the thoracic spine, which is then shifting on the side, and it could also be an additional component to balance the forces that on the other side.
Question I have for you is, when was your first exposure to the first concept of VBT, vertebral body tethering?
Okay, it was a long time ago. First of all, in the 90s, I was fortunate to do a short postdoctoral fellowship with Professor Ian Stokes at the University of Vermont. Dr. Stokes is a well-known researcher in the field of spine biomechanics, who spent a significant part of his career to study growth and the mechanobiology of the spine. And this is where I first was involved in attempts to modify the growth rate and study the growth rate. And my early attempts to study this was on the modulation of the rib cage growth as a mean to either induce or correct the deformity. So that was my early attempts to look at this. So, so the tethering from the rib cage. But after I I became interested in correcting scoliosis without fusion by studying shape memory alloy staples, which concept was to apply loads with a material which could be changed with the temperature and apply a load on the convex side. Then I developed myself the concept with my colleagues, the concept of an intra-vertebral device, which means not to cross the disc, but just to be placed over the epiphyseal growth plate to locally modulate vertebral growth without crossing the disc. And this concept was patented, but successfully tested after on a first rat tail model, and then on a pig model. And we were able to demonstrate how powerful it was to control locally the growth by a local system. And in parallel, I also developed computational models to study the biomechanics of the growth, modulation, and its implication on the scoliotic deformation process, as well as the treatments. And vertebral body tethering appeared in my hand in the mid of the 2000s, and at that time I knew it was first studied on animal models, and so then I developed a computational model to study how it was working. So the models I developed were personalized to the anatomy of the scoliotic patient, and we used them to test various vertebral body tethering techniques. So, for instance, we were tethering the rib cage, the different location of the spine, posterior, anterior, to figure out how it was working, and in parallel, in my group, other colleagues were also working on animal models to further look at the dynamic versus the static effect of vertebral body tethering. Yes. So with all in mind, with all of that, we went to the design of a simulation platform to be able to simulate for a patient-specific patient case different scenarios of tethering, and to finally to figure out how we can best plan the surgery for this given patient and figure out how it will affect the growth over time. So it's a long story.
Oh, it's excellent.
A mix of experimental, mix of computational studies, and also the need to better understand what was happening when playing with the forces applied on the growing spine.
No, it's very interesting to see the evolution of the modeling and the variations in tethering. I'm just curious, what were your results with the tethering of the ribs? It's the first time I've heard of that concept.
In fact, the idea came from early animal studies done in the 70s by Dr. Sevastics and others. We tried to induce scoliosis by playing with the asymmetry, and also my supervisor, Dr. Ian Stokes, also played with the rib cage as a means to induce left-right asymmetry.
Yes.
We found it was not that much powerful to induce the scoliosis, and even for the treatment, it was not that much. So just by playing with the length of the rib cage, it was not that much impactful.
I understand, because it's also movable in terms of the ribs as opposed to rigid body, right? Okay.
Yeah.
So with your interest in a non-fusion scoliosis what do you like about tethering, vertebral body tethering? What what are you uncertain about in terms of your perspective?
Okay. What I like is really the revolutionary idea of controlling the correction over time, and also the promise to preserve the spine growth and the movement, and also the faster recovery. And I think for the patient, for the family, for the surgeon, it's very appealing, because then you can have mobility and a better life. What is yet unclear is what will be the long-term benefits of such technique, and if the long-term benefits will outweigh the reported higher rate of revision compared to fusion. So this is something we still not know, and I think now the issues or the challenges we have is the difficulties of predicting the correction over time, which make the surgical planning very challenging. Now, planning is done quite empirically, based on knowledge, based on the expertise of the surgeon, and but in fact, the surgeon has to decide many different things, such as the levels to instrument, how much tension to apply, and when to time the surgery so as to achieve the optimal correction, which are remaining growth. But the remaining growth is not known. So you have to plan something which results will not, the immediate result you will have after the surgery is not the final result. The final result will come 1, 2, 3 years after. And there are many different unknowns down the road. So this is the big challenge. And this is where our simulators are very useful to facilitate this design process.
Excellent. So let's talk about that. Let's talk about your recent 2020 publication entitled Anterior Vertebral Body Growth Modulation Assessment of the 2-Year Predictive Capability of a Patient-Specific Finite Element Planning Tool and of the Growth Modulation Biomechanics. So in a nutshell, just to shorten that, you're able to predict with very good accuracy outcomes 2 years into the future. So you're time traveling now, I think.
So thanks. Just first of all, just mention that this model was developed by a former PhD student that I supervised in collaboration with Dr. Parent. So her name is Nikita Kobeto. So she's the one that developed the model. And this model takes into account the 3D anatomy of the patient, as well as the biomechanics of the osteoligamentous system of the spine, the mechanical properties of the VBT instrumentation system, as well as the growth process and its modulation due to external forces that are coming either from gravity or the muscles or the correction forces from the instrumentation system. So we developed, at the end, a mathematical model which includes all of that. And with this model, we can simulate either the immediate correction, so the effect of applying the forces with the tether, as well as the gravitational loads that have to balance the forces, as well as the growth of the vertebrae, and how this growth will be modulated over time by the tension as the curve correction will change. So we are just computing at every month cycle how the spine will grow, how the correction will make, and how the forces will be rebalanced. So at the end, we can compute the correction after 1, 2, 3 years.
That's incredible, because so many variables, and trying to put numbers to each variable, that's super impressive. Because your curve prediction outcomes, you were able to predict within 4 degrees at 2 years in terms of Cobb angle progression.
And this is the absolute difference error. So it's not plus 10 minus 10 will make 0. It's the absolute difference error. So, and it's even smaller than the measurement error of the Cobb angle.
Radiographically.
Yeah.
Yes, that's incredible.
Mm.
So, what's the next step in terms of trying to? It's so accurate right now. Are there plans to refine that further on? Are there plans to test that on a larger scale?
Yeah. So the thing is, as of now, we are very good at predicting the correction of the instrumented levels. But also there are additional deformities on the non-instrumented level, which are adding on phenomena. So the peripheral deformities that are coming after are yet a challenge. And also the model we developed was tested with one surgeon locally. So we are now working with other surgeons to further validate it with other techniques.
Now I want to hop back to the initial paper we were talking about. So your prediction capability is very, very accurate for the instrumented part of the spine. So for instance, if you have a double curve thoracic lumbar spine, and let's say the lumbar spine is non-structural, and you tether the thoracic, you're not sure what's going to happen to the lumbar, correct?
Even for the non-instrumented curve, our model is not so bad. It's within 5 degrees. But again, there are certain competitor mechanisms which we are still studying. So we are trying to better understand how the patients are balancing the forces to compensate with this correction of a certain component of the spine. So this is something still needing some research.
Absolutely. Now, a question I have is as well with the paper that I quoted before. It seems that immediate post-operative correction was about 40%, and whereas additional correction respectively of 13% after 1 year and a 3% in the second year. And it seems to be within that range for most VBTs. Now, my question is, why don't surgeons correct maybe to 70% or 75% and let the additional, 3 to 13, 5 to 15% occur over the next 2 years?
Okay, you're thinking as a spine fusion surgeon. So it's unfortunately, if you apply too much too important correction, this will probably lead to an overcorrection over time. Okay. So the VBT system is a very powerful system, and depending on the remaining growth potential, if you have still 1, 2, or 3 years of remaining growth potential, so if you have too much force on the convex side, this will modify significantly the growth rate, and we need to be cautious to select it so you will not have an overcorrection or a correction on the other side, a deformity on the other side.
Sure.
So yeah, so it's not an easy. I
understand, but you know what I mean, right? Well,
yeah.
If it's 40% or 50%, why isn't the target 60, 65? Okay. Right?
The best way to answer this is to use our simulator. With our simulator, we can apply exactly as you said, 75% correction by applying more force, and then we can simulate. And after a couple of minutes, I can tell you, after 1 or 2 years, you will have, let's say, a 35-degree on the right side will be, let's say, a 20-ish in the other side. So this is something I can simulate with a model.
Okay. No, because that's what the first thing I thought about was with your simulator was going. If there's so much accuracy and it's just a matter of course, doing the proper measurements at the beginning, but you just run different scenarios, then the possibilities are amazing in terms of being able to get as close to a good correction as possible without overcorrecting. It's fascinating. love it. Anyway.
And also, another thing we're focusing now is on how to best position the patient intraoperatively, because one of the I would say difficult aspect is when the patient is positioning intraoperatively, there is a immediate correction of the deformity due to the positioning. So the gravitational load, the relaxation of the patient, the anesthesia, and the way the patient is positioned is reducing the deformity. So how much additional force should be applied to reduce the curve this is a difficult question. If you apply too much correction, then when the patient will return in a standing position, then there will be too much forces, which will lead to overcorrection. If there is not sufficient forces, then it's going to lead to an undercorrection. So you need to have the proper adjustment of the forces, and the more the patient is reduced due to the positioning, the less the forces has to be applied. So it's a difficult thing to assess and figure out when performing the surgery. So we hope that with the model we can better understand this and provide knowledge to improve the surgeries.
Okay, excellent. Because I recall that when my son had VBT with Dr. Sam Daniel, coming up to a year, it was interesting to discover that they spent a lot of time with just the positioning. I would say probably at least an hour with positioning him and just to make sure. So now I kind of appreciate why that's the case. It's trying to get as much correction as possible, lying sideline position, I think. Eh?
Yeah, absolutely. So I think this is a component which is not so well known, but most surgeons will feel that it is something important, and I'm not surprised that Dr. Sam Damney is spending that much care to figure out how to position the patient.
Yes, I think experience makes a difference. But I was also speaking to Dr. Noel Larson in terms of they have a specific table that they use for positioning as well, which they use well with every case. So it's very interesting to see how different surgeons approach positioning, because previously I didn't really know there was so much of a primary correction positioning first, then that dictates tether tension.
Yeah, this is a field we studied a couple of years ago, and we demonstrated that positioning is an important component, and especially with vertebral body tethering, it's even more important because it's modifying the initial correction, which is seen intraoperatively. Now I'm collaborating with Noel Larson, with Dr. Larson on this, and we are trying to better understand the relationship between the positioning, initial correction, and the amount of correction that should be applied intraoperatively. So this is an ongoing collaboration, and hope we can provide some knowledge to improve this surgical technique.
Now, my next question for you is that, because you did talk about the positioning lateral recumbent, and you did you're continuing with some studies with that as well. How much correction in general is seen positioning versus additional correction tethering on the table, I guess?
Yeah, in fact, most of the intraop correction is done by the table.
Okay.
And the tether is there first to fix this correction and add an additional supplementary correction. But most correction is done by the positioning. Okay. This is what we found in our studies.
I can see that that information is quite valuable. So I want to say almost that it's kind of worthwhile doing building a specific table that's kind of universal for surgeons in terms of just positioning alone. Okay. Now, my question as well is that if we go to another publication, 2018, and the title of the paper is 3D correction over 2 years with anterior vertebral body growth modulation, a finite element analysis of screw positioning, cable tensioning, and post-operative functional activities. Fascinating again, because just from personal experience with Dr. Sandani, he was mentioning to me that they are experimenting with screw position in terms of trying to increase curve correction, but also work in the sagittal plane with the kyphosis. Okay. Can you talk a little bit about the results of that particular paper?
Yeah, first of all, this is a theoretical study. So we have used a model to test various screw positioning, cable tensioning, and to figure out to better understand the relation between the position of the attachment point of the tether and also the rotation of the apical vertebrae, because the apical vertebrae are also rotated. So the attachment point is, depending on the amount of rotation, could be more posterior due to the rotation. So we found that obviously a lateral attachment point would generate an effect mostly in the coronal plane, whilst a lateral anterior, if there is enough space to be attached there, could generate a concomitant kyphosing effect. But also due to the rotation of the apical vertebra, this may also affect the application of the force vector that is applied by the tether system, so which may even generate more complex forces that could drive the correction. So at the end, a more anterior force will apply more compression anteriorly, so will favor the kyphosing effect, more posterior, a more low dosing effect, more lateral, more in the coronal plane. But if the apical vertebra is rotated, then even if it's lateral, it's more posterior because of the rotation. So you need to be careful. So the thing is, at the end, there are not that much room to play with this position. So the difference is small. But with the model, it was possible to further understand the biomechanics of positioning and figure out how at some point this could be used to, let's say, avoid hypokyphosing or effects, or try to best position the implants in this point.
A question just popped into my head, and it's with respect to your modeling and projecting 1, 2, 3 years out and probably more in the future. Are you taking into account bone growth modulation over that span as well? I guess you have to, right?
Yeah.
Okay.
Absolutely. Yeah. The growth modulation is over the 2 or 3 years that we have simulated. So it's so in the model we need to make some assumptions on this growth rate, because we don't know at first the growth rate for a specific kid. So we need to make some assumption based on published values, and also depending of the maturity of the resource sign or the standard score when we started. So to identify the remaining growth potential, so we can simulate the deformation process and the correction process over adapted to this patient's remaining growth potential.
Now, in that same theoretical publication, you were looking at tether tension as well.
Yeah.
Right. And what were your results from that part of the publication?
As we expected, so more tension will generate more correction. Also enabled us to demonstrate that too much tension could lead to overcorrection. So one needs to adjust properly the tension as well as the location of the screw in order the force vector is properly applied to make the correction to correct the coronal deformity and not introducing too much hyperkyphosing effect. So it's a balance. But we found that properly positioned system in the lateral portion of the spine enabled to do a proper correction.
I have about 50 million things I want to ask you, but I know I'll bring it down to a few.
Can make another interview.
I think we'll have to. Now, a question I have is with, you were experimenting as well with static tension on the tethers versus dynamic, correct?
Yeah, correct.
Can you talk a little bit about the difference between the two and what you've noticed with the differences in methodology?
Okay, so the concept of static tensioning is when we apply intraoperatively with the tether a compression between two screws, then this tension is fixed. So, and one can tell that this is not static because when you move, it will change the tension, but in fact, this tension is, it's not possible to change this tension or this initial length of cord. So this will generate a tension. Of course, this tension will change over time due to the growth of the patient, but also the correction. So it's a dynamic process.
Okay.
When I was referring to dynamic or let's say cyclic, it's like if you, instead of applying a certain force, you vary the force in a short period of time. So this concept came after a colleague of mine, Dr. Isabelle Villeneuve, but also Dr. Ian Stokes, studied how the bone growth was, how the growth rate of the bone was affected by different type of loadings. And what they found is on an animal model is that cyclic loading was less detrimental to the growth plate and the quality of the newly formed bone than the static compression. So with this in mind, we thought that if we can have a system which can cyclically control the body, the tethering, this could improve the quality of the newly formed bone and the health of the spine in general. So that was the idea when we started to look at it.
Okay, and which makes sense because it's more movement in terms of through those growth plates. Were you anticipating if the dynamic cyclic loading would improve correction as well if the bone quality is better? Hard to say.
Yeah. The idea of this concept was to perform a certain correction and have the remaining growth be more natural, but that was the initial concept.
Yes.
So this is why we started to test it on an animal model to figure out if this concept was true or not. And so we developed a prototype of a device which enabled to apply a cyclic loading and tested it on a pig model. And what we have done was more to test the feasibility, but the prototype was somewhat bulky, and it's not something in the short term that could be further implemented. But the idea was to better understand how cyclic loadings or dynamic load could influence the growth rate. Because now all the tethers are developed on the concept that everything is static, but the reality is we all are moving. So we still need to do some research to better understand how the bone is affected by the dynamic aspects of the spine.
Now, with the vertebral body tethering, it was developed based upon the idea of bone growth modulation. And of course, with VBT, there's a very short window in terms of when it's beneficial, when there's 2 or 3 years, 1 or 2 or 3 years growth remaining. But some surgeons are taking the next step and using tethering for more mature spines. Do you have a perspective on that?
Okay. So yes. So in the mature spine, of course, there's no remaining growth potential. So for sure, we cannot use the modulation of growth over time as a principle to play with the correction over time. But bone remodeling, this is a different process.
Okay.
And
how is it different? How is bone modulation different from bone remodeling?
Yes, in fact, one is more related to the addition of new bone, which is driven by a biological process, which is different than bone adaptation due to stresses, which plays with the bone remodeling. So I'm not saying it's not possible, but it's a different process. So at this point, I think we still need to do some research to better understand how this could be done and how it will work over time. So this is something that still needed some research.
Absolutely. Another question I have, since we're on some controversial topics, with stiffer spines, some surgeons feel that they would like to do a bit of a disc release. So for some surgeons, that's incising the annulus. For others, it's removing the nucleus. Additionally, some other surgeons will cut the anterior longitudinal ligament to do anterior release to try and reduce the stiffness in the spine, right?
Okay.
Do you have a perspective on what that would do for the disc long term?
Okay. So I thought the answer is not easy, as there are many consequences that are not fully understood. I would say the best way to answer your question would be to use my model to test the scenarios and figure and analyze the biomechanics of the various scenarios you were referring, so we can better understand how it's working and how what could be the consequences in of performing the different scenarios of modifying the disc or not.
That's an excellent answer.
My best take here.
No, that's an excellent answer, because your model would provide so much predictability. Because I was even thinking as well is that there are different instrumentation hardware. For instance, you have Zimmer Biomet, you have Globus, you have Scoliosis tether. Using those different systems, even using Apifix as well, in terms of, are those possible are those studies that you would consider doing in the future, or are they already in a way?
These are all possible features that could be studied. In fact, just mention that we don't have one model, we have several models. Okay. And over the years, many different models were developed by my graduate students or my research assistants in the lab. And each model was addressing very specific research question, and was adapted to better understand very specific questions faced by the surgeons. So at the end, we have many different tools that could be used. So as soon as you have another question, so test, for instance, another system, so this is something we can develop with the tools we have. So yes, it's possible.
Okay. Now, are you also using the model basically for spines that are not tethered, in terms of what would happen with a scoliosis, 10, 20, 30, 40, 50 years down the line?
In the past, we have used a model to study how the scoliosis was initiated and how it was evolving over time. Okay. But then we have used a model to assess the biomechanics of instrumentation surgery and different strategies. So it was used either for fusionless or fusion surgeries, as well as bracing, which is another system which is applying forces on the rib cage and the torso. So we can use similar models to assess and plan other orthopedic treatments. So it's
very different variables and different applications for the model. Absolutely. Final question. I think we'll have to do another interview because I want to talk to you about your experience with bracing and predictive bracing. But the question I have for you is, if you look into the future 5, 10, 15, 20 years, what do you see in terms of the evolution of tethering for scoliosis?
I think first, in the coming years, we will better understand the long-term effect of tethering. And I think there's still room to improve. And for instance, with the simulation platforms, one could optimize or better plan the surgery, and in order to even improve even more the outcomes. So I think optimization based on the outcomes will be important. And so how could we improve what we're doing by better understanding what is done? I think this is something that will come in the coming years. And I think, this is a revolution because we can foresee not having to perform an arthrodesis of the spine, but it's like an internal brace, something which is modifying the growth over time, which is a more complex phenomenon. And I think it's very promising. First results are very good, but still one needs to be cautious and better understand all the different aspects related to it, and so we can improve in the long term how we are treating our patients.
Absolutely, because I just want to emphasize how revolutionary this concept is. Because if you can predict, if you tether a curve at surgery and you know what's going to happen in 2 to 3 years, that with very good accuracy, that's ridiculous. I love it.
So yeah, so models are very powerful tools, but one needs to be very cautious and have a very thorough validation and verification of models, so we can use them with the needed credibility for the very specific context of use of a given surgery. So this is a very important aspect to take on my side, make sure that the tools are used properly for their context of use.
Absolutely, but I'll just reduce my excitement a little bit, maybe about 2%, but it's very exciting.
Keep some of your excitement for the future.
Okay. Okay. All right. Thank you, Dr. Aubin. Learned a ton, and definitely have to do a second interview because you have so much research and it's so very current as well. So it's very fascinating. Thank you so much.
Thank you very much for the interview. It was my pleasure, and goodbye. Thank you.
Okay. Have a great day.